Starting now. Oh, there we go. We've started now. Hello, everybody. Good evening. Thank you for joining us. Welcome to today's webinar hosted by Vetland. My name is Dr. Stephanie Morley, and I'm the president of Vetland. We're excited to have Dr. Clare Ryan here today, speaking to you about cultivating stewards, antimicrobial stewardship, and the equine practitioner. I'd like to thank all of you for joining and spending the time with us this hour. And I'd also like to thank Dr. Ryan in advance for sharing her time and expertise with us. Briefly, I'd like to explain why Vetland is bringing this outstanding speaker on this important topic to you. Our product, which is called the Vetland Pouch, is a local drug delivery device that allows for daily sustained antibiotic dosing directly at the site of infection. It is refreshed daily with correct antibiotic for up to 30 days. Unlike calcium sulfate beads and other impregnated solutions, if your culture suggests you should use a different antibiotic, you are able to do so anytime during the course of treatment. And when treatment is done, the pouch is removed similar to how you remove a surgical drain. Dosing locally is the most effective method for treating infections while minimizing systemic exposure. And we believe the Vetland Pouch is an effective tool for you to have in your toolkit as you balance antimicrobial stewardship with the needs of your patients. So please visit www.vetland.com to learn more, and feel free to reach out to us with any questions. So a few housekeeping items to mention. If anyone has any questions for our speaker, please put them in the Q&A box. And if you have any other comments or questions about the webinar itself, use the chat box and I'll get to you as soon as I'm able. So now allow me to introduce Dr. Clare Ryan. Dr. Ryan is an assistant professor with the Department of Infectious Diseases at the University of Georgia College of Veterinary Medicine. A board-certified specialist in large animal internal medicine, she brings a passion for equine health, pharmacodynamics of antibiotics, infectious disease, and clinical teaching to veterinary students and clients. After earning her DVM from the University of Wisconsin-Madison in 2002, she went on to complete a PhD at the University of Florida in 2010. Dr. Ryan is a diplomat of the American College of Veterinary Internal Medicine and an active member of several professional organizations, including the American Association of Equine Practitioners and the Georgia Veterinary Medical Association. When she's not in the clinic or the classroom, she's likely deep in a journal article or talking books over tea. So I'm going to hand it over to you now, Dr. Ryan.
Okay. Thank you very much. And thank you so much for the invitation to talk about one of my favorite topics. I am going to go ahead and share my screen and get us started here. Just want to make sure that you can see my slides here.
Yes, we can see them.
Fantastic. Okay. Well, I'm going to go ahead and jump in here and get us started tonight. I'm going to talk to you about a few things, but really the main topic of what I'm interested in sharing with you is some of the ways that equine practitioners can face some of the unique challenges that we have and hopefully become better stewards when it comes to antimicrobial use in our patients. These are learning objectives that were crafted when we kind of sat down and talked about what this little talk could contain in it. And some of the things I wanted to share with you included hopefully giving you an idea of what the relevance of antimicrobial resistance is for equine practitioners and some places where you can identify current antimicrobial stewardship guidelines. Additionally, I want to kind of walk you through some of the application of the antimicrobial stewardship principles, especially as they pertain to certain clinical scenarios, and also to identify ways that you can incorporate antimicrobial stewardship into your prescribing practices in the workplace. And I chose this picture and quote as kind of the start to this talk, because I know that a lot of times we feel a great amount of pressure to be performing at a very, very high level when it comes to antimicrobial stewardship. But in reality, we might feel like maybe vet school was for some of us 20 some years ago. And, or even if it was just a year ago, we maybe haven't had enough practice or enough resources to be able to get us where we need to be. So I just encourage everybody to start where you are and see if we can't find some ways to at least take little steps to move things forward in terms of antimicrobial stewardship. I just have a quick poll for those of you in the audience today, just to start us off here, and I think this should end up showing up in the chat. And I was curious to know what you currently felt you had in terms of access to the resources necessary to make decisions about antibiotic choices. And if you think true or false, yes, I have enough, or no, I do not have enough. And I can't actually see my chat box right at this moment, so I'm going to give us a few minutes.
I'm happy to tell you some results.
Fantastic.
So we have 5 responses so far, and actually 6, and we have 2 that say true and 4 that say false.
Okay, all right. So that seems about right to me. I think a lot of people do have access to some good resources, but many people just don't have enough out there, or at least haven't had experience trying to practice working with some of them and tracking them down. So I wanted to compile for you in the audience today just a nice list of some antimicrobial stewardship resources that are specific to those in equine practice. So probably the one I use the least is actually the American Association of Equine Practitioners, not because there's anything wrong with it, just because it is a little bit more sparse than a lot of the other options. If you're looking for a nice read, this ACVIM consensus statement from 2015 is a bit out of date at this point, but it does have some great points in there. If you are looking for some tools to help you in practice make better informed decisions regarding antimicrobials. This is from the UK, so it's not all 100% relevant to those of us in the United States, but BIVA has this lovely set of resources for veterinarians, and specifically there are some for equine veterinarians, and they actually walk you through a decent amount of information that is really applicable to clinical practice. Similarly, AVMA has a antimicrobial stewardship checklist, and it can be really helpful for kind of pointing out individual things that you can utilize in your practice. And then down here in the bottom, I have this additional, bottom left, I have this additional antibiotic use in horses. And this is actually a document that is out of the University of Minnesota, and it is actually designed for communicating with equine clients. So there's definitely some resources out there if you end up doing a little digging, and I'm happy to share those later on, send that slide on to anyone who's interested. So I have a few quotes scattered throughout this, and I wanted to start off by really impressing upon us the significance of antimicrobial resistance. And this quote by Ken Outerson says, "Every antibiotic we count on now will be destroyed or significantly impaired by resistance." And I think we probably have all in our practice already encountered a situation where we did see or come up against an organism that had resistance to the antimicrobial agents that we were trying to use. It's really frustrating and challenging when that occurs. And I'm going to take you a little bit backwards to your education, just remind you when you were first learning about antimicrobials, you very likely learned some ways in which antibiotics, in which antimicrobial resistance can develop. So over on the left-hand side, in this image, we see that the main ways we can get antimicrobial resistance develop is that we can have pumps that actively pump medication out of the cell, even once they have entered into the cell. We can have enzymes that directly inactivate the antibiotic. We can have compounds or things on the cell surface that can actually affect the uptake and reduce the uptake of the antibiotic into the cell. And then we can also have changes to the target of those antibiotics or antimicrobials within the cell. Once those mechanisms have been brought into an individual bacteria, we certainly know that we can pass those resistance mechanisms along. And there's multiple ways this can occur. It can happen through transduction with these little alien-like bacteriophages. We can have conjugation, and of course, we can directly have mutation where we have addition of or alterations in genetic code that can cause the mutations can occur even without any outside input. And then we can, especially in the laboratory, have transformation. So we can get genetic material that leads to resistance in multiple different ways. And if we think about it, our beautiful little horse here, who is holding on to a bacteria, can spread those resistance elements to different bacteria through multiple different means, depending on where it came from and what mechanisms are available to that bacterial cell. So once we have that, this diagram really nicely illustrates that we can have all sorts of back and forth talk between different bacterial populations, whether those populations might be on the farm level, they might get passed on through vectors like little mice or rats, or I don't know why the guinea pig is running around the farm, but other companion animals or food animals that are on the farm can have interactions directly with farm personnel as well as indirect transmission of bacterial resistance elements. And then, of course, when they come in to visit us in any hospital or clinic situation, they can certainly bring those delightful resistant bacteria to us as well. And it is a huge problem worldwide. And if we look from a One Health perspective and get some information from the World Health Organization, antimicrobial resistance is said to be directly responsible for 1.27 million global deaths in 2019, and it contributed to an additional 4.9 million deaths. So we can really put antimicrobial resistance up there as a very high cause of death worldwide. Misuse and overuse of antimicrobials in humans, animals, and plants are the main drivers in development of drug-resistant pathogens. And antimicrobial resistance makes infections, whether that's in people or in animals, really harder to treat and makes other medical procedures and treatments much riskier. But do we see resistance in horses? I think clinical experience, at least for me, says yes. Yes, I definitely have had situations where I've had to treat a patient who had documented resistance. And so the next couple of slides will just show from a paper that has a very significant compilation of documented resistance in antibiotics, resistance to antibiotics in isolates that were all collected from horse samples. Okay, so I wanted to highlight a few things about these charts. First of all, that these are antimicrobial classes that are being affected that we all use. So penicillin, and you can see that there has been documented resistance to things like strep equi, staphylococcus, and actinobacillus. And certainly we all probably are familiar with or have used third generation cephalosporins like Naxal, ceftiofur. And so we have documented resistance to staphylococcus a little bit, but certainly quite a bit in gram-negative organisms like E. coli. Additionally, if we look at other classes of antibiotics like aminoglycosides, we see some pretty heavy hitting numbers of resistance to things like E. coli. If we are talking about things like chloramphenicol, we will have seen documented resistance again to things like E. coli and R. equi, and then even our fluoroquinolones, certainly some episodes of resistance out there as well too, and we see a fair bit of that in our hospital with some of our the organisms that are kind of the hospital bugs. And then absolutely in macrolides, especially if you live in places like Kentucky or New York or one of the real hotbeds where there's a whole lot of foals, we have some pretty severe resistance problems that have crept up over time as we have used lots of macrolides. So I love this quote because this gives me sort of a perspective and an overall view instead of looking really at the individual patient. It kind of makes me back up a little bit and think a little bit more carefully about the effect on the entire population of horses that I might treat over my lifetime. So giving antibiotics to your patient is like giving them water from a well with a limited supply. You better make sure they need it because there are thousands or millions lined up behind them with the same symptoms. And I try to think about that a lot as especially when I experience pressure from, clients and farm managers and things like that to treat when I have some hesitation about doing so. I try and remember that there's lots of other horses behind them that are hoping to not have to deal with antimicrobial resistance. Okay, I'm going to pause here for a second and we can take a second poll here. So I'm curious about our audience here. When you are making choices about antibiotic treatments for your patients, you consider, do you consider antibiotic stewardship principles frequently, regularly, occasionally, or never? I'll give it just a couple minutes for any answers that come through. And Stephanie, again, I don't have my chat
I gotcha.
visible. Okay, thank you.
Yeah, no worries. So far, we're at a 50-50 between frequently and occasionally.
Okay, cool.
We only have a couple of responses in, but.
Okay. So I think I have been in both, at least 3 of these places, probably not never considered antimicrobial stewardship, but I definitely have been in all 3 of those places at certain points in my career. So maybe part of the reason why we don't always answer polls like this is because I haven't defined for you yet what our goals are and what the purposes are of our antimicrobial stewardship programs and guidelines. And really, there's a whole host of different ways that things can be said and broken down, but when I break them down into probably their biggest categories, anytime I'm thinking about antimicrobial stewardship, things are going to fall under these broad categories. So the first one is prevention of disease. So anytime I can prevent a disease from happening, that's a win. The second thing is to deliberately reduce antimicrobial drug use. And then when I do use antibiotics, I want to improve the way that I'm using them and the effectiveness so that I hopefully can avoid development of resistance. So if we're going to break these down and go one by one, I absolutely love this quote too. I don't know who unknown is, but this one sits really well with me. It's a little bit, it could be Yoda-like, I guess. To learn how to use antibiotics, one must first learn how not to use antibiotics. And I think that's actually quite brilliant. So I think there's a whole host of different ways that we work towards preventing infection, and this is big parts of our job, right? We do many things in our daily practice to support host immunity by maintaining things like excellent husbandry. We clearly spend a lot of time thinking about vaccination of our patients. And then, especially in hospital situations or farm situations, we'll be thinking about things like proper aseptic technique and things like biosecurity in the hospitals as well. Okay, so any way we can reduce exposure to pathogenic microbes or opportunistic microbes would be good. So another way that I think is sort of common sense, but oftentimes harder for us to implement, is actually to reduce use by only treating animals that have confirmed infections. And I am the first one to admit that there are situations where I may not have the perfect culture and susceptibility in my hand before I start treatment, because that would be clinically inappropriate. Our patient might be way too sick or way too vulnerable for us to wait until we have those types of results. But we should probably, at the very least, make sure that results of our physical exam and our diagnostic tests that we are able to perform and get back in a reasonably timely fashion support a diagnosis of a bacterial infection. Like, for example, in this image here, where we have a sample from a respiratory tract and we have some degenerate neutrophils, and we have both extracellular and intracellular bacteria. We also have a whole slew, and this could be a whole another set of 5 or 6 talks, where we see lots of things on the market these days that are ways to reduce antibiotic use by using alternate medical therapies to antibiotics. So there's a whole lot of them. In general, you can categorize them by the antibacterial activity that they exhibit. Could be cause intracellular changes, extracellular changes, or it could really modulate the immune system and make the immune system better able to fight off any pathogens it encounters. I kind of put this box around here. Just this is probably the list between probiotics, antibiotics, vaccines. Those are probably the most common that we encounter in daily practice, but there are some other ones that are out there and accessible to us. Another really great way for us to reduce the amount of antibiotic that gets put out there into the world is actually to use very targeted delivery systems so that we can achieve high concentrations of antimicrobials in the site of infection. And that would be ideal. It can really reduce our need for systemic therapy, and sometimes eliminate it altogether. So examples of this would be nebulizing with antimicrobials, especially, for example, if I am trying to treat a patient who's got a pneumonia and I know I have an organism that's susceptible to gentamicin, and I can't really otherwise get fantastic concentrations where I want them in the lungs, so I can nebulize and get really high concentrations. I think most people are familiar with the concept of things like intravenous regional limb perfusion, where you directly into the vasculature introduce high concentrations of antimicrobials. And then, of course, this is, I pulled this, thank you, Vetlin, for letting me pull this from some of your materials, where we have this antibiotic pouch that is actually being placed directly within this wound, and it will have a catheter and be able to deliver sustained high concentrations of antimicrobials directly to the site where there is infection. So I'm going to hop in here to kind of reinforce some of our concepts here, a little clinical scenario. So I don't know usually when there is a name in my presentation, it's because my child has helped me name it. But in this case, this actually was a client of ours, and I've switched the name and the horse, so you can't actually tell who this is. But we had a 14-year-old warm blood gelding who was admitted with a right dorsal displacement, and it required surgical correction. And during surgery, they performed an enterotomy. And perioperatively, this patient was given gentamicin and potassium penicillin, pretty routine doses and frequencies. And antimicrobials were continued for 3 days and then discontinued on the third day postoperatively. Just so happened that on that day, we obtained notification from the hospital that he had tested positive for salmonella in a fecal sample that was taken as part of our routine hospital biosecurity testing. And so, of course, we have to report this to the owner. And as I call the owner to tell them that their horse has been shedding salmonella in their feces, the owner wants to know, oh, you just stopped the antibiotics. What are you going to treat with? What are you going to treat my horse with? And so this is a little bit hard without an audience in front of me to kind of pull you, but hopefully you've got an answer in your head for how you would respond to this particular owner. And I'll just share with you that even though I have antimicrobial susceptibility pattern here, and I have confirmation of Salmonella enterica, it is exceedingly likely that I am actually not going to treat this patient. So this is one of those situations where I have a lot of conversations with owners about the fact that, the horse has no GI signs, his does not have any fevers at that time. He is eating and drinking well, and really doesn't have any indications that he is systemically affected by this pathogen. And so we're going to avoid treatment. And my favorite thing to share with clients who really pressure me to treat is that we actually have documented that if we treat horses with salmonella with antibiotics, we can actually prolong their shedding of salmonella in the feces. And so we'd like to avoid that if we can at all for their farm's sake and other animals' sake. So to complicate things a little bit more, on day 4 postoperatively, Wally develops a fever. And on physical exam, we can see that he's got some swelling ventrally at the incision site, and it's painful on palpation. So we throw an ultrasound probe on, and we find that there's some anechoic fluid in the subcutaneous tissues, and it's right where it's painful. So we decide we're going to open that site up, and we're going to aseptically collect a culture sample and submit that to the lab. And in a few days, this is what we end up finding on our culture results. So we have an Enterococcus and a Pseudomonas and a Serratia. And so these are, this is kind of garden variety types of bacteria that we would find on when we are swabbing a lot of incisional infection sites. And they feel like really scary organisms, and it's often multiple organisms. And I usually tell the students that these are organisms that are probably coming straight out of poop from somewhere. So really yucky, nasty stuff. And when we look closer and get our susceptibility information on these isolates, what we end up seeing, and forgive me, this is a very busy slide, but I wanted to make the point that we have these 3 organisms, and we get a lot of, in our interpretation column, either intermediate or actual R resistance interpretations to a whole slew of different antimicrobials. And so it's very common for us to see multiple organism and multiple drug resistant infections. And when I see antimicrobial susceptibility test results and bacterial IDs like this, it usually, strikes a little fear into my heart, and I think, oh gosh, this is really gross stuff. And again, I hope that probably you guys are thinking in your head, what might I do in this sort of situation? And it actually has followed through that 99% of the time, we don't actually need to treat with antibiotics. Okay, so most of the time we can manage this with local treatment. And I don't even necessarily I don't usually use antibiotics locally even. We oftentimes are using things that are antiseptic. But establishing drainage and allowing things to exit can most of the time result in resolution of the incisional infections without having to resort to use of antibiotics. And also, then hopefully we're avoiding development of more resistance. So I think this might beg the question. People are asking, well, if you're not going to treat it anyways, why are you taking the cultures? That's a very good question. In this case, we commonly do it because we are very interested in knowing what is in our hospital and what type of susceptibility patterns we are seeing in some of these organisms that are likely floating around in our hospital. So I am in this situation still not going to use antibiotics for this horse. And I can tell you that Wally did in the end. His stay was extended because of the incisional infection, but he ended up doing just fine and going home. So now that I've showed you a couple examples of not treating with antibiotics, we move to a situation where, okay, so now we maybe have a situation that's a little different and we think we really do need to use antimicrobials. So some of the guidelines that we're going to try and follow to improve our use and our stewardship is, first of all, to only use it if there is infection. Ideally, we're going to use lower tier drugs when possible, and we'll touch on that in a few slides later. We're going to use ideally a narrow spectrum antimicrobial instead of a broad spectrum one whenever possible. And then we're going to try and use the least amount of antibiotics possible. Again, this may go back to that sort of targeted delivery of antibiotics as well. And then whenever I can, I'm going to hopefully utilize culture and sensitivity results to help me with my clinical decision making. And I'll show you some examples of how I might use that as we go on. So there's lots of quotes that say this in, a little bit different way. But really, when we're talking about antimicrobial stewardship, it's about using the right antibiotic for the right diagnosis and for the right duration of time. And so in order for us to know what the right antibiotic is, one of the things that I think it is worth explaining and spending a minute to talk about is the different classifications and tiers of antibiotics. And some of the terminology is a little bit confusing. So the WHO, again, this is the World Health Organization, has a lovely publication where they go through the classifications or tiers of antibiotics. And they use in this documentation what are called medically important antimicrobials. Okay, and you can see there's a whole scale here where on the right-hand side, there could be a low risk of antimicrobial resistance to develop. And on the flip side of things, there are other antimicrobials for which there is really a high risk for AMR developing. And the way that they define risk, because this is, of course, a human health organization, the criteria they use are that the antibiotic is the sole antibiotic or one of limited antibiotics available for the treatment of serious bacterial infections in people. And then also, they do take into account that if there are antibiotics where you could get transmission of the resistance genes that could come from non-human sources. And when we lay out all of our antimicrobial choices onto that list and look at kind of those classifications from the green, which is, all not used in humans at all, so they're not really important for humans, all the way up to these red classes, which are the highest priority of medically important antimicrobials. We see where most of our antibiotics that we use come into play. So we do have quite a few of them that fall under just highly important. Some of them fall under critically important, and that's actually some newer information and reclassification has put aminoglycosides into critically, and they used to be just high importance. And then we have a few of our antimicrobials that we use that are really considered very high priority. And so maybe they are not the ones we should be reaching for as our first line antimicrobials. So this is an example just from our hospital here at UGA, where for equids in the hospital, they very nicely have given us tiers in terms of guidelines for what we should try to reach for first, if at all possible. So in our hospital, we still are considering gentamicin to be a tier 1, as well as some penicillins, including amoxicillin and ampicillin. We don't really have any first generation and second generation cephalosporins that we routinely use. So kind of ignore that one, but things like tetracycline and TMS are also considered tier 1. This tier here is probably where a lot of our patients get treated in, but not all of them. If we are able to achieve a diagnosis and we think that there is a reasonable alternative that's in tier 1, we will definitely try and reach for that first. If we are pretty sure that a first tier antimicrobial is not going to work, well, then I'm not going to start with that first tier. That doesn't actually make sense, because then I'm giving them probably 2 antibiotics when the first one fails. But I'm certainly going to think about it before I give a tier 2 antimicrobial. And we have significant restrictions and a whole committee who deals with it if we were to end up having information that suggested we need to use a restricted or protected antimicrobial, but we try very hard not to reach for those. Okay, so I am going to switch to, I think, one of the hardest, most challenging things to think about and apply when it comes to our veterinary practice, which is using antimicrobial susceptibility testing to help us choose an antibiotic. So on the face, when we get these antibiotic test results back, susceptibility results back, it seems like it should really be easy, right? I just look in this column here where there's an interpretation, and I go, okay, well, I'm just going to pick an S. There are instances, though, where I think it is appropriate to ask, oh, gosh, can I use that I? Can I use one that it has an intermediate susceptibility? Are there ever situations, Dr. Ryan, where you would reach for one that has an R on it? And indeed, there are. And the next little segment here, hopefully, will share with you a little bit about why I might choose things and go a little bit deeper than face value on these AST reports. So in order to explain what gets put onto that report, I'm going to actually back up for a second and just point out to you that we have our interpretation, but we also have this column here, which is the MIC. And for anyone who needs a refresher about what the MIC is, most of our labs will use determination of MIC, which is called the minimum inhibitory concentration, using the dilution method. So the way that that works in the lab, as we have our lovely broth that our bacteria love, we put our test bacteria in there, a certain amount of it, and then we let it grow up, and then we prepare separate dilutions of a specific antimicrobial agent, and then we are actually going to take that bacteria and inoculate the same amount into each of these tubes. And then we're going to see what grows. So in this case, I made this so you could see little bacterial growth in there represented by our little yellow bacteria. And so there would be visible growth in the lower concentrations of antimicrobial agent. And then in the ones where there's higher concentrations of antimicrobial agent, we get no growth. So the MIC, by definition, is the lowest concentration that prevents visible growth of bacteria in the culture. And so in this case, that would be this little tube here. Obviously, this is ramped up and pretty has pretty good automation at this point in time, so it's not as much labor as it used to be. But same concepts apply. So I think it's really critical to point out that when you obtain MIC data, it only applies to one bacterial isolate. In your case, this is the one that you submitted to the lab and that they identified, and one antibiotic. Okay. So you cannot compare MICs between different bacteria or between different antibiotics. And I do find that this can be a point of confusion amongst students and health officers, and sometimes my colleagues as well too. So even though you might have a number and know a number for example, erythromycin for a particular isolate, you cannot directly compare that number to and apply it to get any information about a different other antibiotic unless they are very, very, very similar antibiotics. So now if we have the MIC, minimum inhibitory concentration number, that we've obtained from our isolate, and we need to know what to do with it. And we need to know what is our MIC breakpoint. And I'll walk you through what that MIC breakpoint is here. So MIC breakpoints, I'm going to start with the definition, is the concentration that separates sensitive isolates from resistant isolates. Okay. So up here, I want to point out that MIC breakpoints are all determined based on the MICs of a reference population of isolates. Okay. So that's what's showing in this little graph down here. So on the y-axis, we have the number of isolates that have been inhibited at a particular MIC. So for example, a few isolates had inhibited growth down here way at a very low MIC. And up here, we had a whole lot of the organisms of the isolates in this population that were susceptible at this MIC. And then as we get further up and have higher concentrations of antibiotic at increasing MICs, we see this little population over here that kind of breaks apart from the rest of the crowd. And it actually, you have to have such high concentrations of antibiotic to be able to stop growth from occurring that those end up separating themselves from the herd, so to speak, and they are considered resistant antibiotics. So if we have a population of 1,000 isolates, and we graph them all out here, we can find that there is a certain amount of them that will be resistant and a certain other amount that will be susceptible. And the number, the concentration that splits those populations is the MIC breakpoint. Okay. So we actually have some references that supply us with this breakpoint information for a given concentration of bacteria, as well as the antimicrobial that we're testing. Okay, so I just took this graph here and I said, okay, we've split that population up, and then we have some references that will give us some interpretive criteria based on MIC breakpoints. So down here, you'll see that for low, those isolates, if my isolate that I send to the lab has a really low MIC, that means that it is the interpretation for it is going to be susceptible. If it is a higher MIC for my isolate, I'm going to compare that to the breakpoint, and I might find that if it's greater than 2, then it is resistant. Okay, and so that's where your interpretations of S, I, and R come from. Okay, so who determines or who comes up with all these breakpoints? Well, there's a couple of different big organizations that test this criteria, and they gather tons of data from lots of different places where they can set the standards for saying, okay, we've got this organism and antibiotic combination. And in the population of those isolates that have been studied, what's the cutoff between the susceptible and resistant isolates? So this is CLSI, and this document comes from CLSI, the one that is in the middle here. And then there also is a European version of this, the UCAST, and they do excellent work over there in Europe as well too. Our laboratory, most of our big laboratory diagnostic labs here will use a combination of data from both of these places. And so they will hopefully, we hope, be using as much information as we possibly have. And this is the way it gets presented in the CLSI information. So for example, I might have a fun isolate of Bordetella, and it'll tell me from the data that they mined and looked through, okay, there's a lot of isolates that were taken from the respiratory tract, and then it will tell me the antimicrobial agent that was tested against it, and they are able to look and provide some MIC breakpoints and interpretive criteria for us. And then if there's extra comments, for example, this ampicillin is close enough to amoxicillin that you can actually use it to predict the results of the other one. So really a lot of information in these things, but it's not perfect, especially when it comes to veterinary medicine. So there's some real limitations of MIC and MIC breakpoint usage. The first of which is that this is just in vitro data, meaning we're growing these bacteria in artificial conditions. So we're growing them just overnight in an aerobic media incubation with a standard number of bacteria in a liquid that's got really low protein, which doesn't necessarily mimic where infections are, and at a certain pH. Okay, so those are maybe not the most realistic of conditions, and so this really often does not mimic the site of infection. The determination of MIC breakpoints also incorporates things like pharmacokinetic and pharmacodynamic data. Excuse me. From both animal and human studies. We oftentimes don't have necessarily useful information if we are just looking at serum pharmacokinetic data. That's oftentimes not really relevant to where the infection is. And then also these breakpoints, they do use some clinical and bacteriological outcome data from clinical studies, and that would be fantastic. We would always prefer to use that if possible, but there are not that many overall in vet med, and there's fewer even in equine than even small animal as well. So if we think about sites of infection, they're often acidic, anaerobic environments. You may have a lot of protein there that might bind and inactivate our drugs. We might have a lot more bacteria than there are in the test tube, and they are not in an exponential phase of growth. So clinical trial data is always best, but we don't always have them. So what the heck do we do if we don't have that information? And I like this quote too. If you know which drugs kill which organism and where they distribute in the body, you can design a regimen to treat anything. Maybe not anything, but point taken. So this is the final point I'm going to walk you through and show you a couple cases is clinical application of MIC when there is really no appropriate CLSI or UCAS breakpoint data. So in order to walk you through this, I have to remind you of some of the antibiotic characteristics, as well as we need to know some information about how the antibiotic is processed and moves throughout the body. So the fancy ways of saying that are going back to vet school or other classes you've taken where you look at the pharmacokinetics. which is absorption, distribution, metabolism, and elimination of antibiotics. But even more importantly, for our purposes, the pharmacodynamics. So that is what happens, how does that antimicrobial interact with target tissues in the body? So you probably remember a little bit about when you take a drug, it goes into your bloodstream, and over time, the drug concentration increases, and then it gradually decreases over time, and this happens at different rates for different drugs. You also can have a whole slew of different pharmacokinetic terminology. The big ones to remember for our purposes are the Cmax, which is just the top concentration, the max concentration of the drug that occurs. And then the other one is area under the curve. And all that is the mathematical representation of this amount of antibiotic that falls in the blue space there. And then if we know that information, we can oftentimes plot out and compare it to the MIC that we already have established. So just reminding you that there are concentration-dependent and time-dependent antibiotics. And for antibiotics that are concentration-dependent, like, for example, our fluoroquinolones or aminoglycosides, our goal is to really maximize the concentration. So we run a super high Cmax. And so we would like to see that at least 10 to 12 times, for example, for aminoglycosides above the MIC of our organism. For fluoroquinolones, it's a little bit more dependent on this area under the curve number, but we want that to be significantly higher than our MIC. A little bit different for our time-dependent antibiotics, like, for example, beta-lactams like penicillin. Really, our goal there is to keep the amount of time that we spend. So from here until here, we're above the MIC, and we want to maximize the time that we spend above that MIC. So typically what we're trying to reach for most situations is that we want to be above the MIC for greater than 50 to 80% of our dosing interval. And I don't want to forget about other factors that make antibiotics useful in certain situations. Their metabolism and excretion, if they are ones that are really good at getting inside cells and across membranes, if they get bound and inactivated by protein and things like that, those are all very important as well too. But a little bit more than we can cover tonight. So I'm going to give you a little bit of a very brief application here, a couple cases that combine the use of pharmacodynamic data, where we look at drug levels in tissues, and MIC data. So really the ultimate question is, can I use this antibiotic to treat this infection? And in order to answer that question, I need to know three things. One, what is the tissue concentration? So pharmacodynamics of this antibiotic at the site of infection, and ideally in horses. Two, what kind of antibiotic is it? Is it concentration dependent or time dependent? And then the third thing I need is to know the MIC breakpoint that's been provided by the CLSI or others. So let's apply this to a case where I just want to know. I have a foal, and the foal has sepsis, and I would like to know if I can treat the foal with a cephalosporin called ceftazidime. So I need to know three things, like I just said. One is the tissue concentration. And so on this graph here, the y-axis is concentration, x-axis is time. And so these black lines here give you the tissue concentration, which in this case is our plasma samples. So this is in the blood. I know what the tissue concentration is over time. Okay, so the type of antibiotic, okay, I know that this is a cephalosporin, and I know it's going to be a time-dependent antibiotic. So I'm going to want to keep the concentration above the MIC for as much time as is possible. And then I also need to know what the MIC breakpoint is. Well, at the start of this I have to treat my septic full before I have my data. So I'm going to take a guess about some common organisms that might infect foals, and I'm going to look at breakpoints for generic Enterobacteriaceae. And so that would be the blue line here, and something with a higher MIC, and that would be Pseudomonas in the red line here. So those are two MICs that are plotted out against that graph. So I'm going to combine all of that information together, and I'm going to look and I'm going to say, oh gosh, yeah, look at this. I can keep my concentration-dependent antibiotic above a certain level for a good period of time. And now I just have to decide, am I going to give it every 6 hours or every 8 hours? And I can make that decision based on the rules we know about time-dependent antibiotics. We would like to keep it above the MIC for at least 50% of the dosing interval. And so depending on, what kind of MIC I'm looking at, I may decide that I need to use every 6-hour dosing or every 8-hour dosing here, even before I can take some educated guesses as to predicting what my MICs might be of common organisms. Okay. And so in this case, I mentioned that tissue levels are really important, but in this case, when we are talking about sepsis, we actually are really interested in knowing our blood levels, because that a lot of times is where our bacteria are starting, and that's what's causing the fevers and allowing the bacteria to distribute throughout lots of different tissues. So we actually are interested really in what our blood levels are, and we can use that. Okay, this is our last one. We are heading home. And so this is a completely different case scenario where I'm going to walk you through a little bit of a difference for a situation using an antimicrobial like azithromycin for Rhodococcus equi infection. So I gave you some rules and some things you need to know. So let's walk through those. So first I need to know tissue concentrations. Okay, well, over here in this table on the right is some information where we have serum concentrations and we have time after a dose of our antibiotic is given. Okay, time in hours. Okay, so we also know what type of antibiotic this is. Number 2, it's a macrolide antibiotic, and this is, in this case, a concentration-dependent antibiotic. Okay, so I would like to get a really high concentration achieved. The third thing I need to know is what is the MIC breakpoint. And in this particular study, they were looking at a population of isolates that had a breakpoint of 1 microgram per mil. So if I compare that 1 microgram per mil, and then I look over here, and these are indeed in microgram per mil, whoa, we have a problem. My serum concentrations are really, really low compared to what the MIC breakpoint is. So it really maybe doesn't look like out at this time point, this is going to be an effective drug for us. Okay. But we also know that we use this antibiotic to treat R. equi infections all the time, and it works clinically. So what piece of the picture are we missing? And this is where pharmacodynamics of this medication come into play very significantly. So what we're looking at here is a little bit bigger of a table, but what this table provides us with is some information about pharmacodynamics of azithromycin and the concentration of azithromycin that we can achieve in lung. Okay, so over here again is the time. We have that same serum data right next to it, and now we're actually looking at concentrations of antimicrobial in actual lung tissue and lung fluid. And if we remember that the MIC was 1, and we compare these numbers to that, we can see that we can actually really achieve very high concentrations in the pulmonary tissues for long after the last dose was administered. Okay, so that's why, because azithromycin concentrates so heavily in lungs, we can achieve really high levels there, and it's very useful for treating infections, even though our serum levels are very low. This is very similar data, just looking at clarithromycin instead of azithromycin. They both accumulate very nicely in the lungs. Okay, so I've shared a lot with you, and I feel like I have given you a lot of information. I'm tried to talk as fast as I could, but hopefully we've got the idea that it's a very complicated topic, but that some steps forward, some antibiotic stewardship is better than none. And I would encourage you to hopefully be a little bit less intimidated by some of the diagnostic test results that we have. And then just as a exit thought, I had another poll, if anybody cares to answer in the chat, about ways that you think you might like to promote antimicrobial stewardship in your practice, and just provide you with my contact information. And once again, a giant thank you to Vetlin for allowing me to talk at you guys today. And I'll be happy to, if there is any time, take any questions. And if there ends up not being time, I will be more than happy to answer any emails if anyone would like to send me some.
Thank you so much, Dr. Ryan. That was fantastic. We'll give us a few minutes to just make sure we get some questions answered, and see if we can get anyone to take a stab at your last poll you put in.
Okay.
So one question would be, how can someone find help to navigate the CNS results when they do get them back?
Yeah, this is the culture and sensitivity results can be really hard to interpret, and you may have some good resources at a couple different places. One is I do consults all the time, and many other institutions, the internal medicine crew will do a lot of consults about antimicrobials. So I'll put that out there. The second thing is oftentimes the laboratory itself may be very helpful because they have access to those CLSI guidelines. And all of the primary references are in those CLSI guidelines and UCAS guidelines. And so they may actually be able to point you to kind of the primary literature and help you get access if you need additional information. And then, of course, some of the resources that were kind of put on that very first slide with some stewardship resources. You can kind of go down some rabbit holes.
Wonderful. Hopefully you didn't sign yourself up for too many consults.
That's okay.
Okay, how would you recommend talking to clients about the need for culture and sensitivity?
Oh, this is such a good question. And especially, I feel like in academia, we kind of have it a little bit easy because, we it's kind of assumed that we're probably going to take cultures, et cetera. But I did do private practice for 7 years and encountered all sorts of different situations where I did certainly get pushback from people saying, we don't need that. The other vet in the practice doesn't do that. And, things like that, where there's definitely can be some pressure to not do it. So if I do nothing else, a lot of times I'll just collect the culture and hang on to it. And if the case goes perfectly well and I don't end up needing it, fantastic. But I definitely have found that, sometimes when there's like a joint involvement or tendon involvement or something like that, where people said, oh, we don't need that. Boy, were they really happy when I had it stored away in my fridge and I can submit it when the case was not improving the way that it would. And I definitely talk to people about things like antimicrobial resistance and try and get a little bit of buy-in in terms of, well, we might not use these results, but if we're 4 days down the road and we're not better, we might know what to switch to if we have some susceptibility data and culture data.
Great. That's awesome advice. Well, I think that's it for our time. I want to really thank you for joining us and talking about this topic. I learned a lot myself. And thank you to everyone else who attended. We really appreciate it. The entire Vetland team is happy to be working with all of you and helping make our patients healthier. So thank you for that. And we will have the webinar posted and CE certificates available soon. So look out for those.
Thank you.
All right. Have a good night, everybody.